I'll go ahead and record now. Okay. All right. Just a reminder to everyone, this is an interactive learning community. So when we do have our breakout groups, please put your microphone and your webcam on to participate. And then when our speaker is speaking or any other time we're not in the breakout group, please feel free to use the chat function to type in any questions. We will have someone monitoring that. And if you are calling in from the phone, just a reminder, it is *6 to unmute and *9 to raise your hand. And then lastly, please rename your profile to have your name and your organization. And you can do that by hovering over your picture and clicking on the 3 dots and then choosing rename. All right, and I will now pass it over to my colleague, Dr. Jennifer Hallandi. As many of you know, she does head our early intervention efforts at the University of Minnesota ICI, and she will be our facilitator today.
Thank you, Courtney, and welcome everyone, and happy summer to everyone. I thought we'd have a smaller group. I know for many of you last week, and I know many of you work all year long, but I know for some of you, last week was your last day. So thank you for being here today. We're happy to see all of you. And if it's your first time today, welcome. And again, I think most of you are familiar faces, so welcome back. I'll just quickly cover some additional housekeeping pieces. Again, we are Project Scope, which stands for Supporting Children of the Opioid Epidemic. We focus on Neonatal Abstinence Syndrome, or NAS, or Neonatal Opioid Withdrawal Syndrome, NOWS. We're a community of early intervention providers supporting children and families. And we use an ECHO virtual training model. I'm going to talk a little more about that. Next slide, please, Courtney. Oh, so here is a video, a 1 minute or under. Many of you saw it that we're on last week, but it's a really quick description of what Project Scope is. We're one of many Project Scope sites across the country. Courtney, you can go ahead and play that. Hopefully we'll have sound.
Children affected by the opioid epidemic and its related trauma have unique needs. Their families require additional support, and providers who support them must have the right tools to promote healthy development. Project Scope, or Supporting Children of the Opioid Epidemic, is an innovative national training initiative intended to standardize, develop, and expand educational practices to give providers the tools and the confidence to best address opioid-related challenges impacting children and families. Through collaborative video conferencing technology, Project Scope utilizes the ECHO model to bring together early child care and healthcare professionals and other service providers. Outcomes for children, families, and early care systems will be improved through interdisciplinary education and skill development, especially in historically difficult to reach and hard-hit rural areas. Project Scope provides practical applications of advanced and real-time research findings. For providers, it means better knowledge and skills. For children and families, it means better outcomes and hope. Learn more at nti-scope.com.
Thank you, Courtney. That was a nice quick video sort of overlaying what our goals are here. Next slide, please, Courtney. So again, what is ECHO? ECHO stands for Extension for Community Health Outcomes. Our goal is to promote health equity, share knowledge and expertise. We want to reduce disparities and increase access and provide healthcare without barriers, bridge healthcare and education settings, and have a community of practice that sort of links the medical world and the education world, the clinical world all together. Our belief is that knowledge should be shared and that we're all learning from each other. It's bi-directional. We bring different speakers and experts, and then we also learn from our community together. So next slide, please. And again, the 4 principles, you hear it every week. We use technology. We always do these over Zoom. We use best practices to reduce disparity and increase access. We always do a case study, so please stay on for the case study at the end. It's where we apply what we learn, and we will always send out a survey where we collect data to monitor outcomes and get feedback on the learning, how it's going, what topics you want. We will run another ECHO session, another Project Scope session next fall, and we'd love to hear what you want to learn more about. Next slide, please, Courtney. And we're in session 5. So for those of you that have been here since session 1, you've made it past the halfway point. We're at session 5. We're gonna go all the way to 8 sessions. So there we go. So our agenda for today, we've done the welcome. I'm going to introduce our speaker today, who we're so happy to have. We'll then do our case study, breakout groups, and then we will wrap up. We may even be done early today. Who knows? It is a beautiful day, so it'll be nice to get outside. But without further ado, I am going to introduce our speaker for today. Welcome, Lisa Bayley.
250.
I think someone needs to mute. Thank you. I will do a quick introduction of Lisa. Lisa Bayley is Deputy Assistant Commissioner of Children and Family Services for the Minnesota Department of Human Services. She's responsible for services and policies that promote childcare, child support, economic stability, child safety and permanency, and successful transitions for immigrants. Bayley offers oversight and direction to Children and Family Services Administration, oversees child welfare and public assistance policy, and coordinates projects across children and family services. She also supervises child well-being initiatives for counties, tribes, and partner agencies, leads operational activities, and represents children and family services for the department at large. Before becoming Deputy Assistant Commissioner, Bayley managed her own law practice, Bayley Law, LLC, in Red Wing, Minnesota. Prior to that, she was a prosecutor for Hennepin County and Wabasha County's attorney's offices. She served on the Red Wing City Council for more than 8 years, including 2 years as council president. And Bayley has been an active volunteer for numerous state and local nonprofit organizations, including the Children's Law Center and Hope Coalition of Red Wing. Lisa, it is so nice to have you here today. We're so excited to hear your presentation and your perspectives, and we just all want to welcome you. And with that, I'll turn it over to you.
Thank you, Dr. Hallandi. I'm pleased to be here again. Thanks for that nice introduction. I'm Lisa Bayley, Deputy Assistant Commissioner in Children and Family Services Administration. Basically, it's a fancy title, means that we're the area of DHS that works on everything related to children and family services. And so that's, as you mentioned, child support, child care, all forms of economic benefits and supports, and then, of course, child safety and permanency, which is the child welfare system, which is the topic we have today. And I'm going to give you a pretty high-level overview of how our two worlds intersect, and then open it up for questions, discussion. I can tell you most about what my background is in, which is in literally the nuts and bolts of the child welfare system. But want to keep brainstorming and talking about ways we can work together in other ways as well. So first of all, let's go to the next slide. And actually, I'm going to go to the next slide. So across the country, child welfare systems are seeing a significant increase in the number of children involved in child maltreatment reports and in foster care as a result of parental substance abuse disorder or substance use disorder. In national data, the percentage of foster care placements where parental alcohol or other drug use was a contributing factor in the decision to remove a child almost doubled from 18.5% to 35.3% from 2000 to 2016. Now we don't have the data to pull out opioid use in particular, although we know that that is a significant contributing factor here. So I'm talking about substance abuse. Now using comparable data in Minnesota, actually, and we're going to go to the next slide, but over a shorter period of time, the percentage of removals where drug use was a contributing factor almost tripled from 14% in 2010 to 40% in 2019. There were 6,497 new foster care placements in 2010 and 6,596 in 2019. Young children are especially likely to enter foster care due to parental drug and alcohol abuse. In Minnesota, of all children under 6 who entered out of home care, 55% of removals involved parental drug use, compared to 27% of children 6 and older. So we know that the youngest children are really impacted. Next slide, please. And the consequences for the parental drug use are significant for children. And I'm sure well known to all of you, children are more likely to experience educational delays, lack of routine medical and dental care, and mental and behavioral health problems, including, of course, their own substance abuse or use disorder. Specific to the child welfare system, children who are removed due to parental drug use have longer stays in care and were less likely to reunify or get back together with their parents, and more likely to have a termination of parental rights. Specifically, of children who exited foster care in 2019 in Minnesota, children whose placements was related to parental drug use spent 4 months more in care than their counterparts where parental drug use was not a factor in the removal. And we know, particularly for the younger children, every day that a child is out of care has an impact on them. Next slide, please. Now, while foster care is sometimes necessary, there's also good evidence in research studies that children who can safely remain in their homes do better than children who experience foster care. We take from that we should and are trying to do everything possible to keep children with their families. Specifically, one MIT economist, Joseph Doyle, found in multiple studies that children who stayed with their families fared better than their peers who were placed in foster care, controlling for other demographic and context factors. Doyle found that children who remained at home were less likely to be involved in the criminal justice system, less likely to become teen parents, and generally earned more than those children who were in foster care. And in another study, children who were in foster care compared to peers with at least 3 other socioeconomic disadvantages were 5 times as likely to experience depression, 4 times as likely to exhibit behavioral problems, 4 times as likely to feel anxiety, and 3 times as likely to have attention deficit disorder. In another study, yet another study conducted in the 90s, Kathleen Moby and other colleagues found that babies who had been born addicted to crack cocaine but remained at home with their families were doing much better developmentally 6 months later than babies who were placed into foster care. So that's a really significant piece of data right there. Slide 7, please, or next slide. Now, we also know that Black, Brown, and Indigenous people are more likely to experience punitive responses to drug use, generally speaking. For instance, they're more likely to be arrested and convicted of crimes related to drugs than their white counterparts. And this shows up in child welfare as well, especially in the racial bias in reporting for prenatal exposure. In one study, researchers found that despite similar rates of drug use, Black mothers were 10 times more likely, if you can believe it, 10 times more likely to be reported to Child Protective Services during pregnancy than white mothers. In Minnesota, African American children and American Indian children were 3.5 and 10.5 times, respectively, more likely than their white counterparts to be reported to child protection for prenatal exposure to drugs and alcohol in 2019, which I think that's the most recent year we have for that data. So just think about that, 10.5 times more likely American Indian children. That is really our deepest shame and the one thing we are working very, very hard to address. We know that 1,450 babies were screened in for allegations of prenatal exposure in 2019 total. Next slide, please. So what are we doing to address this? Given that young children are especially likely to be involved in child protection and foster care with parental drug use as a contributing factor, and the disproportionate reporting of African American and American Indian infants with prenatal exposure. A major area of concern is responding to the care and treatment needs of infants with prenatal substance exposure and their families. In the last few years, there have been increasing attention at the federal level as well related to prenatal exposure to drugs and alcohol. For instance, now in order to receive Child Abuse Prevention and Treatment Act, CAPTA funds, states are required to ensure that we operate programs relating to child abuse and neglect that include the following measures: policies and procedures to address the needs of infants born and identified as being affected by substance abuse or withdrawal systems resulting from prenatal drug exposure or from fetal alcohol spectrum disorder. We also need to demonstrate that we have the development of a plan of safe care for infants born and identified as being affected by substance abuse or withdrawal systems or FASD, to ensure the safety and well-being of infants following their release from care of healthcare providers. So that's sort of a new emphasis in the last couple of years. Next slide, please. The Department of Human Services has multiple strategies for supporting local agencies in meeting this requirement that went into effect in 2016. And just to remind everyone, we are a state administered county or state supervised county administered state, meaning that all of the services, of course, I'm sure people here all know, are actually provided by the counties and tribes, and the Department of Human Services oversees that and works in collaboration and partnership with counties and tribes. So we have multiple strategies for supporting local agencies in meeting this new requirement that went into effect in 2016. Since the first year of implementation, there have been significant advancement in the use of safe care plans to ensure that pregnant and parenting mothers of infants have the services they need to safely care for their children while receiving either inpatient or outpatient treatment. And in order to support that work, Child Safety and Permanency, which is one of the divisions I oversee, has partnered with Minnesota Hospital Association and the Behavioral Health Division, which is in another area of DHS, in the development of a roadmap to provide hospitals and health systems with evidence-based recommendations and standards for the treatment of pregnant and parenting women of infants with substance use disorder, including the development of plans of safe care. This work has included engagement with local child welfare agencies to better understand how child welfare and hospital systems can better meet the needs of these parents and children. Additionally, in 2019, the Department of Human Services released an RFP that resulted in grants to 4 jurisdictions to learn more about how local communities can build a coordinated collaborative to develop and implement a plan of safe care to address the safety and well-being of families when babies are identified as having been exposed to substances or alcohol. So far, the results of those local collaboratives have been positive. A high percentage of infants with a plan of safe care are safely remaining in their homes with services to address the needs of both the baby and the family. I think it's a little too soon to say how positive the results are because our data lags, but so far the trend has been very positive. Next slide, please. Other strategies, in 2018, the federal government passed the Family First Prevention Services Act. And that one significant change, it's a very large and significant piece of legislation that's something I actually do know about and have spent quite a bit of work on. One thing that has happened is that it gave the ability for local jurisdictions to be reimbursed for up to half of the costs for the care of eligible children placed with their mothers while receiving inpatient chemical dependency treatment services. And it took some time for us to get all of that in place, but Minnesota currently has a limited number of inpatient treatment programs that allow for the co-location of children with their mothers. So and we could talk more about that, but that just getting that one piece into in place, I think was a significant step forward. Recently, the Minnesota legislature passed a bill that will go into effect on July 1st of this year, which provides that a healthcare professional who's mandated to report a woman's use of controlled substances does not need to make a child protection report if the reporter is collaborating with the other healthcare professionals to provide the mother and infant with care. And so that's that I'm sure you'll be hearing more about that, but that is we're trying to remove those barriers to providing services and keeping the child out of the child welfare system if it's not necessary. Next slide, please. So what can mandated reporters do? You know, we know that African American and American Indian mothers are much more likely to be reported to child protection for drug use. And so important that mandated reporters dig into that anti-bias, anti-racist work alongside the Department of Human Services. It's something we are extremely committed to, and we ask for your partnership in that. It's absolutely critical to address racial bias at the individual, interpersonal, institutional, and systemic levels, to give white people the tools to examine their own racial bias, both unconscious and, as we all have it, conscious and unconscious. It's critical that we work to increase diversity within all of our places of work at all levels of the institution, all of the decision-making levels, and to invest in communities and families early before they're in crisis, instead of waiting and feeling like the only thing we can do then is to report those children to those families to child protection. We're looking out. This is something that I am in particular working on right now, is making our system more coherent about finding opportunities to meet families' basic needs and support their strengths early, rather than punishing them for the system's failure to provide those supports. So we're looking for ways that we can upstream provide supports for families in crisis, in poverty, facing substance abuse problems early in the system, rather than allowing them to be, or not allowing them, but rather than having the result be that they are reported to the child welfare system. We know that 65% of the children who are reported to the child welfare system are reported for neglect, not as most people think, for physical abuse or other kinds of abuse. And so we're looking at how we define neglect and what we can do to address those sort of root causes. We know that this is not easy, but we also know that the communities that have suffered at the hands of our systems and institutions just can't wait, and we need to address it at that level. Next slide. I think that's the end. Yeah, I think there we go. So I just want to again thank you. I'm happy to take any questions you might have, and see if you'd care to have, I know we have a little time, have any conversation about this and address everything as best I can.
Well, thank you so much, Lisa. That was a great presentation. So much interesting data. I now just want to open it up. You're right. We have a little bit of extra time for questions. And Courtney's going to watch the chat for me, but I'm going to start with a question. I'm going to throw it out, and I ask the same question every time, but there's a different answer contingent upon the area of expertise. But as I said in the beginning, we have a group of early intervention providers here predominantly. Many work in Part B and Part C, early childhood special education. And I guess if using your knowledge base and your understanding, most of them are mandated reporters, and I appreciated your slide at the end. But what tips or strategies or advice might you give them? Again, I really appreciated that slide at the end around mandated reporting. But what do you think is most important for them to take away today?
What is most important to take away?
Big question, I know.
That is a big question. I think that statistic I just gave about the 65% of children that are reported to the child welfare system are reported for what we term neglect.
Wow.
Is a really significant piece of information. And I think this is my personal opinion based on my role, my years in the child welfare system myself. representing parents and children. I think that we all tend to want to report things because we're worried about the child. We're worried about safety. We're worried that if we don't report this, of course, you're mandated, right? So I mean, that's a significant thing. But I think, and when it's mandated, it's mandated. I mean, you have to do that. But I think keep in mind that when neglect is the reason, you know, to question why you're reporting something and to think, is there a more appropriate avenue for me to address the concerns of this family? Knowing, just I think, I guess now that I think about what I want everyone to really hear is that placing a child outside of the home is a dramatic, impactful action that should not be our first response.
Sure.
And we know that children who stay with their mothers at the early age do better, significantly better in terms of development and otherwise. We know that children who stay with family members, even if it's not their mother, so if they're allowed to stay with kinship, we call kinship care, that should be the first resort, not to place the child in stranger care. And I will say that foster parents and stranger foster care is absolutely sometimes the most appropriate and the best outcome for children. But we want people to hear that there are often other avenues of assistance, and to keep that in mind, whether it's through the county, through calling DHS, through other providers, but to keep in mind that if we can find another way for stabilizing that family early, rather than waiting for something to happen, that's going to lead to much significantly better outcomes.
Great. Thank you. Thank you. Very helpful. Courtney, are you seeing, I'm not seeing the chat right now. I can take a look.
I don't have any questions in the chat. Oh, a few just came in. Let me see.
Okay. She's just gonna.
Okay. Brenda asks, how can we all do better at coordinating referrals from CAPTA to ECSC providers? That's
going to be outside my topic area. I will have to get a response for you on that one. That I don't know the answer. I think I will get back to you with that one.
All right, and then we have one more from Debbie. Many of the children that we receive referrals on that are in foster care have been removed at birth due to exposure. I have worked in the Birth to 3 program for 4 years and know that in our district, very few kids have been removed due to our reporting. What work is being done with other agencies to reduce this bias?
And by the bias, you mean the exposure, the prenatal exposure. You know, what we're doing, we're hoping to use the funding through this Family First Act, which will ultimately be able to provide us 50% reimbursement funding for prevention services, to continue working on rather than waiting until that we have a child who's born who's had exposure, to addressing those issues earlier, and whether that's through substance treatment, or providing that in person, the dual treatment, so that the child can be with the mother. We have a lot of educating to do of child care workers, rather, attorneys, judges. There are a lot of people who have, in some cases, a well-founded medical belief, but a really strong bias towards removing the child completely when there's been that exposure. And it's not always the appropriate avenue. Sometimes it is, but it also sometimes it isn't. And so we have a lot of education to do on our end. And I guess we just ask, if you have ideas of things that we could be doing better. As I said earlier, we're trying to be more purposeful about how we approach upstream prevention services in providing families with whether it's treatment, and then really some basic basic needs, which healthcare, housing, employment, I mean, all the basics of human services, but how do we do that in a more comprehensive way that is really addressing those families that are most in need and really doing it before they get to the point of reaching the child welfare system? That's a great question. It's something we grapple with. We're still looking at that. And some of these legislative changes, if you have thoughts on things that we could change, like barriers you've reached in terms of, for example, we have one, the Safe Harbor, a Safe Harbor Act that has not been passed yet regarding if a mother wants to leave a child at a hospital, have a baby at a hospital, and then leave the baby there. Right now, she can't do that because even though we're supposed to have no punitive action, because of course the hospital has a mandated reporter action, and so they have to report that, and then the mother gets in trouble, and then they're separated. And so we're trying to address that. We haven't gotten that legislation changed yet. The one that I referenced earlier is an example of we're trying to remove some of these barriers where there's sort of unintended consequences of legislation that make it harder for you all to do your job. So if you identify things that you say, gosh, if only somebody knew that stupid law is preventing me from really being able to do things correctly, let us know that, because we make changes all the time. Some things take a couple of years to get through, but if we don't know where the problems are, then we can't make those changes. So please reach out to us on those.
Thank you. It looks like we had another question come in. When children are referred from CAPTA, it can be difficult to establish eligibility for early intervention unless there is a documented delay. How can early intervention be part of the solution before children are removed / caught up in the CAPTA system?
Well, I guess I'd throw that back at you, what the folks on this call. I mean, what are ways that we could, if we were able to remove that documented delay requirement, would that address the problem? And then would that lead to problems because we didn't have a documented delay? I mean, is there some way around that? If there was something we knew that we could try to change on getting past that limit, I think we could work on that, getting past that barrier rather.
And at least we've talked in some states, not Minnesota, but right now it looks like there's about 12 states where neonatal opioid withdrawal syndrome or neonatal abstinence syndrome is an auto qualifier for Part C. We're not one of them, but it's certainly a question and interest this group has because it's another way to bring children into a supportive and families into a supportive system early on. So that'll be, I'm looking, Courtney, can you read some of the comments?
Yep, we just got policy changes needed in Minnesota to open early intervention services for prenatal exposure to drugs and alcohol. So like you were just talking about the auto qualifier.
Right. A lot of members of this group have talked about that and how can we look at the policy and potentially change it. I think this will be for next session when we do another 8 sessions, but we'd really like to dig into, and this would be maybe more of a policy, what have these other states done? How did they make it happen? What are the benefits? What are the challenges, potentially unintended outcomes? So it'd be interesting to kind of do a policy analysis on that.
This is a great example, though. I mean, I love this one because this is one where it sounds like people are frustrated. This is something that is a barrier. And if other states are doing it differently, why can't we? I mean, there may be a reason at some point someone's demonstrated or verbalized, but I think we could absolutely work on that. And that's exactly the kind of thing that actually our commissioner has kind of tasked me with addressing some of these things, these upstream ideas where if only we could get rid of some of these barriers, we could address families in a better way. So I love that idea, and I'd love to work with you on that for this next session.
Absolutely. Part C to me is a model of supporting families and children in a very family-centered way. And you think, we're looking at children and families that have been affected by neonatal abstinence syndrome or NAS. how can we support these families? Looks like there's a few more. I think we have time. Lisa, you're generating lots of questions, which means people are very engaged in your presentation. Courtney, can you continue to read those for me? It's just easier, and it's
a couple comments just agreeing with that need. And then another question, do folks who treat substance use know about Part C services and make referrals? I'm not sure.
I don't either, but I know people in my division will know, and I mean, that may be if that's not happening, that may be something we can close that gap.
Yeah. And that question, I'm not sure who asked that question. That's a great question. That's another when we talk about the bidirectional learning that happens with this ECHO, this scope, project scope. That is definitely, for example, I'm going to give you an example. Courtney and I have joined several groups related to this project where it's mainly medical providers. So it's medical providers, as we've had present here, those that treat mothers and those that work with babies with NOWs. And certainly we're learning a lot about the medical world around that, and we bring to them sharing about early intervention. So to answer that question, I don't know if all of those providers do, but I think it's an opportunity for us to intervene and educate that the expertise goes both ways, that early intervention providers clearly understand how we serve families, how we serve children with developmental delays, and how can we work better with the medical system so we're providing families what they need. And Lisa, having you here today brings in this really valuable policy lens of, if we're going to look at supporting families and not being punitive, what are some of those policy interventions that we can do? How can we work together? It's a great opportunity to bring people from different systems, different areas that support children and families, and say, how can we work together for change? All right. Are there a little more? I'm seeing a few things pop up. Courtney, do you want to? Lisa, I will tell you, this is the most questions we've gotten.
Yay. Good.
So it's nice to engage.
Yeah.
Courtney, can you read those to me?
Yep, just a couple comments. Amy says, many children my program works with do not receive evaluations or interventions because parents are not in a place of acceptance that there could be concerns related to development. Therefore, they fall through the cracks. Susan,
absolutely.
As we are growing in Minnesota with what we know now about how many children and families are impacted by substance use disorder, she says these statistics are appalling. Part C criteria is an area where we as a state can respond in a proactive and preventative way. We receive many referrals from hospital staff for toe-exposed babies, but a large number of these babies get screened out due to our current eligibility criteria.
That's toxic. Just I think it was a typo. Yeah.
Okay.
Yeah.
That's it. This is something we've also identified with as that it's a self-imposed problem that we have here because our eligibility criteria in a couple of different programs are such that we either inadvertently screen out people or we inadvertently screen in people that shouldn't be. And so, for that, I'm thinking of our definition of neglect. And then this would be an example of where we inadvertently screen people out. So those are the kinds of things that we're taking a hard look at right now. And thoughts from this group, we would love to hear that about what your thoughts are of what we could do differently or specific, especially if there are specific areas we should be looking at in terms of eligibility criteria.
Absolutely, Lisa. And I think it would be something too that would be interagency, because I know DHS owns a piece of the expertise, but I know MDE would need to be at the table as well. But this group,
sure.
Yeah, this group, as well as MDH, this group has a lot of good ideas. I'm wondering, can they reach out to you? Can we share your email?
100%. Yep. This is what I do. So I would love it. And, I've got an amazing staff of people. We have incredible resources in terms of our research and data evaluation people who, crunch the numbers and are really always digging into that. So whatever, if we can provide that data to you, we're always willing to share that. Of course, it's all public. and then we'd love to talk policy talk. So if
Absolutely.
ideas, whatever it is, yes, definitely forward that.
And we appreciate your openness. We want to see early intervention at the table. We've got a whole room of experts in the area of working with children and families. So I think you have a lot of people who would be happy to partner with you on that.
Fantastic. I'll tell you, while I'm not by any means an expert in the area of the early intervention and the medical side of things, we are working on this idea about trying to be more intentional in terms of prevention services with MDE, with MDH, with the Children's Cabinet. So we're trying really intentionally to be much more, trying to get rid of some of these silos. And I think several people have referenced them here that, how is it that so-and-so doesn't know that such and such is available? And so we're trying to work on that and working on information hubs. One really significant thing that's happened, and now you've got me a little off my topic, but this last year is that as a result of this group of people getting together, and through a huge amount of effort, we did a memorandum of understanding between the different agencies on data sharing. And I'm sure this group knows that one of the huge problems is that the different agencies can't share data, and they'll say, why don't we just call the education department? They'll know this stuff. And they say, well, we're not allowed to give that to you. Well, we've got a big umbrella agreement now between the agencies. It took like hundreds of lawyer hours to get this all figured out, but we're really hopeful that is going to be, there are going to be some real benefits for that in the next couple of years, where we can do a lot more data sharing and a lot more just getting information without having people having to apply for the same services multiple times, and without being quite, we want to be respectful of privacy, but without being quite so siloed in how we use our information and our data. So that I think you'll see some good benefits from that.
Absolutely. Absolutely. Well, thank you so much, Commissioner Bayley. I really appreciate it. Were there any other questions? I know we have our case study coming up. Adele, were you about to ask a question? Oh, okay. All right. And Courtney, you don't see any more questions in here. Well, I trust they can reach out to you. Again, I have talked to several members of this ECHO Learning group, and I think you have some really willing participants to work with you.
Great. I may be reaching out to you, and I will find out about a couple of the questions that I didn't have the answers to, and I'll get back to you.
Absolutely. And Courtney can send it out to the group because we send out an evaluation as well as a summary of the talk.
Great.
So
great.
Thank you so much.
Thank you for having me.
Yes, thank you so much.
Okay.
And enjoy the evening and the rest of the beautiful day.
You
We're
too.
going to move on to our case study, but we
Sounds
so
good.
appreciate this wonderful didactic. Thank you.
Thanks, everyone.
Thanks. All right. Well, thank you everybody for your comments and questions. What an engaged group. Now I'm going to transition over to my colleague, Dr. Adele Dimian. And I don't have her bio in front of me, but I know her well enough that I'll just share a little bit about her. Dr. Dimian does both research and clinical work in early intervention. She helps co-lead our telehealth lab and has done a lot of early intervention and behavioral support work in areas such as self-injury. And she also is an expert on data analysis and data visualization, which I greatly appreciate as we work on grants together. Welcome, Dr. Dimian. I look forward to your case study today.
Thank you for that very nice introduction, Dr. Hallandi. Appreciate it. Hello, everyone. Thanks again for joining us on this nice day. It was hot and humid down here in the cities last week, so we're finally getting a little bit of a reprieve, but I hope you have some nice weather where you are. So I'm going to go ahead and dive right into our case today. This case primarily will be on the following topic areas: trauma, social determinants of health, including foster care, addiction, language development, sensory concerns, unknown prenatal exposure, and self-regulation. And the child we will be talking about today is 34 months old, and they are living in a foster care home setting. They attend child care full time, and they do get visits with their biological parents about once a week. So a little bit of background. Thank you, Courtney. This child has been in foster care since April of 2019 and in their current placement since June of 2019. She has an older half brother who's 11 years old and a younger sister who's 17 months old in the same foster placement with her. Her parent has a history of substance abuse and in incarceration, and her biological parents have multiple other children in other placements. The foster parent is a developmental specialist with the early intervention program. So some strengths about this child: they do have access to an early intervention team, including an occupational therapist consult, it looks like. They also receive early intervention and CRC services that are provided in the natural environment. So some current challenges are obviously with the pandemic, but providing all these services virtually, which I'm sure a lot of you today on this call can tell us about your experiences, or will be interested to hear during our case discussion in the breakout rooms. So the early intervention provider is missing out on seeing multiple settings, and so they only see them typically in the child care setting or with visits with the biological parents since the pandemic. And the third birthday is approaching for this child, and they're about to transition to preschool services at the same time of this potential change also to a permanent placement. So the primary concerns: this child has a communication delay and experiences quick, intense, and often frequent mood swings. Some of the common triggers, stressors, or factors related to primary concerns for this child are that adults try to redirect her and keep her safe, obviously, but transitions to routines or activities that are not the child's choice are difficult. Transitioning back to foster home following just knowing or discriminating the difference between the different adult expectations across those settings. So some strategies, interventions, or other things that have been tried and the extent to which they've been successful include the following: sensory strategies. So heavy work, brushing, weighted compression vests, using a calming space, modeling deep breaths, doing an I love you ritual with a twinkle twinkle, books with emotional themes, picture schedules, first then statements, offering choices, a referral to the Children's Resource Center, early childhood mental health consultant, using video visits or consults once a week with the foster parent, where the child participates, but it sounds like that was difficult for them to participate in. And finally, what they reported was the best results that they observed from these strategies that they tried were the heavy work and compression vests, the deep breathing, and the I love you ritual, as well as offering choices and the support from the CRC, which is the Children's Resource Center. So the goal for this case and what we want you to discuss is any additional ideas for success with self-regulation for this child, how to support the possible transition to that new placement or new permanent placement, and from them back to the biological parents. So now we're going to go ahead and break out into our rooms. Courtney will put you in there. Again, feel free to use the chat or use your mic and camera to ask any clarifying questions right now. Otherwise, you can talk about your recommendations. Please do nominate one person to report your answers when we join all back together. But these are the 3 following questions that we would like you to discuss. Number 1, how does developmental delay, receptive communication, cognitive, expressive communication delays impact the child's response to self-regulation strategies? 2, how long should strategies be implemented before you can determine success? Is the strategy working or not? When do you move on and try something else? And then finally, what self-regulation strategies have been found to be most successful with 2-year-olds? So we look forward to hearing your recommendations for this case. Let us know if you have any questions right now, but Courtney's going to go ahead and break us apart. And remember, or into the rooms, remember, please nominate somebody to come back and at least either write them in the chat or feel free to unmute and use your video to share out.
Yeah, we don't live far from Lake Nokomis, and that has been really hopping. Everybody's been there, and sometimes June it's too cold to swim, but it's been nice.
All right, it looks like most of us have rejoined. We've lost a few people through the transitions. Transitions are hard to understand. So we'll go ahead and wrap up here. Thanks so much. I hope you guys had a good conversation in your groups. Feel free to go ahead and either type in the chat, or if you'd like to unmute and share with, we're a much smaller group too. So now, so if you feel like you're comfortable to do that, anyone want to share kind of their first recommendation about if the developmental delay impacts that child's response to those strategies discussed? Oh, good. Thank you, Susan, for sharing. We discussed in group 1 the importance of focusing on attachment and the need for that child to have a really strong sense of security, especially when given all these upcoming changes and different providers coming and going and relationships, and really focusing not as much on the self-regulation, but the co-regulation with those people around this child. Thank you for sharing, Susan.
Yeah, Susan, I'm really glad that your group brought up the attachment issue. We could have a whole presentation. I touched upon it last week, but in terms of some of the attachment risks and the need to do a lot of developmental repair with children who, have obviously been removed or are in a situation where a parent is still actively using or in recovery, but having depression. So yeah, I think the attachment piece is so important to bring up. Sorry, Adele, I know you're, but
No, thank you, Jen. And Tiffany, thanks for sharing. Less words are better, more processing time, using a calmer approach, using some of those visuals and more communications, probably between those different settings or transitions, I'm guessing. Some tangible items, yeah, maybe like a lovey or something like that gives that child some comfort and security when they're going to those different settings. First then, and offering choices. And also, yeah, so it depends on how long the caregivers and how consistent you can be with transitioning back to parents and what that looks like. I agree. It seems to obviously be a big factor, obviously in this case, but it does seem to play a big role. And then, yeah, those deep breaths and heavy work, outdoor play. Yeah, good recommendation there, especially this time of year, right? Get some of that energy out maybe in a productive way when it's not humid and hot out, hopefully.
Or freezing.
Or freezing. Yeah. We're at a very slim margin of time.
Narrow window here.
Yeah. I think those.
I like the less words, the better. That's something no matter how much I cognitively know it, it's like I have to remind myself. I mean, that also works. I work a lot in autism. That's kind of one of those universal techniques. Simplify the language. Yeah.
Absolutely. All right, I think we had 2 more groups. In our last 2 groups, go ahead and share if they're still on. Either about the second one is interesting, right? Like how long should these strategies be implemented before you can determine success? There's a lot of great strategies in there, but knowing when something is working, or making sure that you're not piling on too many things all at once, or using different strategies across the settings and being able to discriminate when she's tending to use different strategies. To me, this speaks to, some data collection, which is probably sometimes a little easier. We were talking about to do via tele when you're seeing them in the same kind of setting over and over again, but also giving this child some choice around what strategies they want to use, perhaps. Anybody else had any thoughts about when to deem a strategy successful?
What do you think, Adele?
I base those decisions on data, typically, but if you don't have the data, then I tend to rely on observations to see what's going well, what's really motivating for the child, what can they do pretty easily, especially when they're upset. Those are the types of strategies. And some of those strategies we talked about, like first then or visuals, those sometimes are great strategies for the more so for the people around that child than the actual child. And so it helps build a consistent relationship with that child if everyone's doing something consistent using such as those visuals or first then types of strategies. All right, does anyone want to, we'll leave a little bit early. This will be a reward if we can get one more chat in here, or if someone wants to share just any from their own scope of practice, what self-regulation strategies or strategies in general that they think are useful and successful with 2-year-olds. I have an almost 2-year-old, and I will take any advice from anybody. So feel free to pile them on. Susan, were you going to share?
I was texting Erin. She and I work together. I'm a school social worker in our program, and so I don't provide a lot of direct service to these little ones. And my friend brought her granddaughter over the other day, and she's 2.5. And her parents just had a new baby. So, world on fire, right? Mm-hmm. And I got such a workout. And I was a preschool teacher before I became a social worker. I got some tricks. But man, I had to be on my toes the whole time. And I was saying wooden nesting dolls save the day. But there has to be the ability of any care provider of young children to have an array and to know when to use different things from the array. And when we know a child has experienced trauma or there's a big thing that's happening in their life, it isn't so much this strategy is consistently effective. It's how do I, as the adult, adapt and shift and respond to those cues. And that's what Erin was saying about serve and return. What's the child telling me with affect, with emotion, with expression? And then how do I respond? Because the ways in which we respond, it isn't just strategy, it's what's our affect, what's happening with the mirror neurons, what's happening with what are we putting out there that the child is seeing, and how does that interaction either help regulate or escalate? And so I was reeling. I was real tired. I needed a nap after that. I'm not kidding. Mm-hmm. Wooden nesting dolls, get some of those. They help.
And Susan, that's such a good point. I mean, kids have such a powerful barometer for what's going on around them, and they so sense, if an adult is calm. And I'm not saying as a parent, I always follow this advice. But, they really can sense it. So it isn't always so much the specific strategy times, it's what we're sort of channeling as well.
Yep, absolutely. So
yeah, that parental or just caregiver responsivity. Yeah, it's such a good point, Susan. It looks like Jean did share some calming strategies: star breathing and smell the cookies blow. Oh, I don't know that one. If anybody wants to demonstrate, go ahead. Scented bubbles, sensory play, breathing ball, scented Play-Doh. So a lot of sensory types of activities, social stories before and after. Yeah, I really like that idea of a social story, especially again with all those transitions that this child has to do. In after the visit feeling, so almost like debriefing, setting this child up for success, and being, I think, transparent with this child about who they're seeing, when they're seeing them, may help in terms of that communication to build those relationships across the different caregivers in her life.
Well, this is great. There's a lot of good ones here and some new ones too.
Absolutely. All right. Well, that's it. I think we did our job today. Thanks so much, everybody, for sharing and being with us in this space and having these tough conversations. We really appreciate it. Courtney, I think we'll follow up with our next round, and I will hand it off to Dr. Hallandi.
Thank you, Adele. And thank you everyone for your great thoughts and insights and strategies. And what a wonderful discussion we had after the didactics. I think this group really there's some good policy advocates in here. So we really appreciate that. So you know the drill. You'll receive an email to complete the REDCap survey. Please offer your feedback about this session, but also what you'd like to see. Our plan is to offer another session in the fall, and you're welcome to rejoin it again. We'll have some of the same speakers, but some different ones, but please offer feedback. We will offer a certificate of participation, but you have to complete the survey in order to get it because we want your feedback and thoughts. Next slide, please. Next, we look forward to seeing many, if not all of you, for session 6. It'll be Indigenous Approaches to Family-Centered Care, and we're really looking forward to it. Next slide. And thank you for all of our participating partners, Minnesota Lens, Project Scope, ICI, where many of us work at the University of Minnesota, our Tele-Outreach Center, and the Minnesota Act Early Project. And thank you to all of you for participating in this ECHO, for learning with us and teaching us as well. We so appreciate your time, and we look forward to seeing you next week. Thank you so much. And you can go enjoy your evening. Go enjoy the lake or the outdoors or the ball field or just a walk. But it's supposed to be nice tonight. So enjoy. Happy summer, everyone.
Thank you all.
Yeah, take care.
Bye.
Bye. All right. It's 1, 2, 3, 4, 5. I think Judy, are you there? I think Judy might have walked away. How about Becky?
Yep, I'm still here.
Oh, hi, Becky. I wasn't sure if you would do it.
Canceled. Yeah. Yeah, sorry, something canceled today, so I got to pop in.
Oh, I'm glad you popped in. It was nice. Should we, Judy, you're welcome to stay, but I think she walked away. I know Judy. I think we can release her. Courtney, Adele, I guess I have the power too. There we go. Okay. All right. Well, we're done early. That was a good discussion. Nice job on the case study. It's always funny to